mute yourself and let me know, okay? Welcome everyone to our inaugural Ask the Doctor Zoom session with Dr. Zonder. Okay, I'm going to mute Sid first. Okay. I'm so pleased to have you all here. And today, I'm so fortunate that we have Dr. Jeffrey Zonder with us. Dr. Zonder is Professor of Oncology at Karmanos Cancer Institute and Wayne State University School of Medicine. I also want to thank our sponsors, Bristol Myers Squibb, Amgen, Karyopharm Therapeutics, Adaptive Biotechnologies. In these difficult times, we truly are appreciative of your support. The way this is going to work is Dr. Zonder will provide us with a little background of himself, for those of you that don't know him, and then give us an update on multiple myeloma treatments, and then followed by his research into a COVID-19 treatment using multiple myeloma. So it should be really interesting, multiple myeloma medication. We have an hour or so once Dr. Zonder is finished, we'll open it up for questions. I've taken some questions from you already, and we'll start with those. And then anyone that wants to ask a question can use the chat button. It's in different locations. Oh, I can see. It's in different locations, depending on whether you're using a phone or a tablet. So just see if you can find your little chat button and press it if you want to ask a question, and I'll relay those to Dr. Zonder as we get farther into this. And then if we have time at the very end, I will also open it up and unmute you so that everyone can talk, or you can unmute yourself anytime too to ask questions once we're that far. So I see what I'm doing here. I have to admit people from the waiting room. So I'll keep doing that. But right now, what I'd like to do is turn it over to Dr. Zonder, who can start with a little bit of a background on himself and then take it from there.
Hi, everybody. Thank you for the invitation to participate today. This was originally going to be real lunch together somewhere, and it's with everything that's happened, it's turned into the first virtual meeting this group's had. I guess we're all getting a little bit used to this at this point, a few months into the COVID-19 outbreak. So it's a little hard to talk about myself sometimes, and it's even harder to just sit here in a room by myself and talk about myself. But I'll just explain our program. I work at the Karmanos Cancer Institute, which is an NCI designated comprehensive cancer center in Detroit. We're affiliated with the McLaren Health System and also with Wayne State University. And I run the multiple myeloma and amyloidosis research program, and also our multidisciplinary team. My focus is mostly clinical research. That's what I do. I'm not a transplant physician, but we have transplant physicians within the myeloma program. Also, we have basic scientists working on biology questions related to multiple myeloma and related conditions. The Karmanos Cancer Institute is a member institution of the Multiple Myeloma Research Consortium, and we're also active participants with the Southwest Oncology Group's Barlagi-Salmon Myeloma Committee. The other docs here who are sort of centrally involved in the myeloma and amyloidosis program are Drs. Andrew Kinn and Dr. Abhinav Deal, both of whom are transplant physicians, as well as having non-transplant clinics. And then there are at least half a dozen other doctors who do hematologic malignancies and sometimes see myeloma patients, but aren't as thoroughly focused on it as the three of us are. So that's us. I don't know, did Sid want to say anything, or
He was on, then he left, and Sid, I don't see him anymore. I think he
Okay.
lost. Let's see if I can find him on here.
If he wants to jump back in anytime, just interrupt me.
Here, I unmuted Sid. There. Sid.
Let's go forward. We're good.
Okay.
We're good.
All right, we'll just keep moving.
I
Sure,
can keep
sure.
moving.
All right. Well, so with this many people on, and it's and not everybody on the call has really had a chance to introduce themselves, and so and I kind of anticipated that this would be the case, but under the best of circumstances, when you have a group this large, everybody has very different needs in terms of what they want to get out of a session like this. When we do this in person over, lunch, it's very unstructured, and we should try to, I think, maintain that sort of format for today. I can, just briefly, what I thought, what I sort of came prepared to talk about a little bit was just to mention, a recent development in the myeloma landscape, which is the approval of subcutaneous daratumumab, which is a really nice thing, for myeloma patients. It's as we know, daratumumab is an antibody therapy that targets something called CD38 on myeloma cells, and it's approved for use by itself in relapsed myeloma, but it's also approved for use upfront and in relapsed disease in various combinations, including with lenalidomide, with Velcade plus melphalan, with pomalidomide, and now there's data about combining it with Kyprolis, carfilzomib. So it's a very widely used medication, and traditionally it's an IV medication, which at the outset of therapy is given over 6 or 8 hours in the community. The day one dose of the first cycle is sometimes even split into 2 separate days, just to get it all in. And it does speed up over the course of therapy, but generally always runs in over at least a couple hours. And the sub-Q version goes in over 5 to 10 minutes, more like an injection of Velcade. That's just a major improvement in terms of convenience for patients. And it'll totally change the flow of patients through treatment areas. It'll make it easier for patients to get in for needed treatment because there'll just be more space in infusion centers to get treatment. So, the approval was based on a randomized study which showed it was exactly as effective as IV daratumumab, and had a safety profile that was at least as good and maybe slightly better in terms of infusion reactions. So we're going to move. We've been participating in clinical trials that utilize sub-Q daratumumab for some time now, both in myeloma and in amyloidosis. And we're going to rapidly adopt the sub-Q as soon as it's truly available commercially, and I think most centers plan to do the same thing. So that's going to be a major change in treatment. The other thing that I wanted to talk about is related to the recent COVID-19 outbreak and sort of how that's affecting myeloma treatment landscape, and what Karmanos is doing, what other centers are doing, and sort of what research is ongoing right now that's particularly relevant for myeloma. In some areas of the United States, like in Detroit and New York, where in Seattle certainly, where there were heavy rates of infection early, we're probably on the back side of the curve now. We're probably on the shoulder heading back down past peak. There are other areas of the country, particularly some rural areas or slightly smaller cities in other states that are just now accelerating into their peak. And so on the whole in the country, we're still a bit on the upswing, or at least not clearly past peak nationally, I would say. It has definitely impacted therapy for myeloma patients in a number of different ways. The data that we have, which is mostly from China, and is suggests that cancer patients may be more prone to this infection. It also suggests that cancer patients may have worse outcomes. We don't have a lot of prospective American data yet on this question, but everybody is rapidly scrambling to amass that data. Still, based on the information that's available, we're taking precautions. And so, in myeloma patients, certain kinds of therapies like stem cell transplant, where there's good data to show that the timing of transplant doesn't matter so much as the ultimate availability of transplant. Transplants have been put off at a number of centers. Most centers are just now starting to emerge from the bottleneck related to transplant. The schedules of some therapies have been modified. For instance, going back to, a great example is going back to the daratumumab that I mentioned, or elotuzumab, a different antibody, which are often given weekly or every 2 weeks. Some of those infusions have been changed to monthly to just minimize the number of visits that patients have. Or when those drugs are being given in combination with other medications, particularly oral medications, the antibodies have been skipped at our center and at many centers for a cycle or two while the oral components of the regimen are being continued. And then we're doing a ton of telehealth visits. We're doing clinic volumes in general are down. A lot of routine follow-up visits are being pushed out. But for patients who do need active follow-up, but who are on oral medications, for instance, a lot of those patients are getting labs done locally and then doing our visits with telehealth. At least a third of my appointments for the last month have been conducted by Zoom or Microsoft Teams or Doximity or other platforms, but we're doing a ton of telehealth right now. And I think, I think, to be honest, this might be a little bit of a wake-up call, I think everybody is thinking about, well, how is this informing our understanding of our preparedness for future things like this. But just stepping back beyond pandemics and infections, I think a lot of patients are realizing that telehealth can be a very valid way of connecting with a physician. And, especially for, niche type conditions like amyloidosis or plasma cell leukemia, or, frankly, multiple myeloma compared to some other kinds of cancers. I think patients who are accustomed to traveling 2 or 3 or 4 hours to be seen at, a comprehensive cancer center may be doing some of that follow-up by telehealth in the future. The patients that I've had who travel like that to see me, I think it's been a humongous wake-up call. Things might be better in 3 months, but let's make our 3-month follow-up telehealth also, because it's easier and you can accomplish 90% of what you do at an appointment, by getting local labs and then just talking to each other. So I think that's I think that in terms of the treatment landscape lately, I think those are the big things. Maybe before I talk about specific research related to COVID, maybe I'll stop rambling for a minute or 10 or 15 and let people ask questions about treatment, about how their treatment's been affected, or about new things that they've heard about.
So I have a few questions that were emailed to me prior. Would this be a good
Mhm.
time? Because these are not necessarily related to the COVID. They're about themselves. Should I do that now, you think?
Sure.
Okay. Um, all right. The first question is from Nancy Haida, and it's, can Revlimid speed up the progress of cataracts? And she wants to know also if it affects someone's vision. So this must be something that's, that's possibly been happening. So.
Right. So generally speaking, Revlimid doesn't have ocular toxicity. Generally speaking, Revlimid doesn't have ocular toxicity, but it's usually given in combination with steroids or with antibodies that require steroid premedications. And dexamethasone and other related steroids can absolutely accelerate the rate of cataract development. Also, steroids can also have an acute effect on vision in terms of sort of ability to accommodate and focus. And so it does sometimes make it harder to focus right on the heels of a steroid a dose. But longer term cataracts, absolutely a steroid complication, not a Revlimid complication.
Okay. And the second question is, are the shingles vaccines recommended for those who have had bone marrow transplants?
Short answer, yes. We're talking about the new vaccine, the Shingrix vaccine, which is not a live vaccine. Once you've recovered sufficiently from transplant, you can be getting your standard post-transplant vaccinations, which is at about 6 months. You could potentially be a candidate for the Shingrix vaccine. It's a 2-part vaccine, as I understand it, a more potent and effective vaccine than the live vaccine that was available previously. So yes, we are recommending this for our patients. We don't know yet if it can replace, so when you're on certain medications and you need to be on prophylactic medication to prevent shingles, we think that it's likely having had the Shingrix vaccine would be sufficient prophylaxis, but we don't know that yet. And so I'm still counseling patients to take acyclovir, figuring that the vaccine and acyclovir are at least additive in terms of their protectiveness against shingles reactivation. When you're on Velcade, Ixazomib, Kyprolis, daratumumab, isatuximab, all of these meds require shingles prophylaxis, and I still tell patients to take that.
So next question is from Karen Nichols. She lives in Clio. Her question is, when will the sub-Q version of Darzalex be available?
Darzalex.
And what are the advantages and disadvantages?
Well, that's what I was talking about before. I mean, I think it is FDA approved. In terms of its availability, there is usually a little bit of a delay with rollout of new medications. But I know, like, for instance, our hospital formulary committee is already working on, the documents to start providing subcutaneous daratumumab. And we're going to rapidly switch all of our patients over. Every patient who has insurance authorization to make the switch. There will probably be if other medications that have gone sub-Q, like rituximab, a different antibody that's used to treat lymphoma, is any indication, there'll be a slight increase in the cost of the medication for the new formulation. In terms of advantages, just as effective, slightly less toxic, and 1/10 the time, in the chair. So, I mean, that's the main thing about it. So I expect that most people will have access to it, within the next couple of months.
That sounds great. That's really wonderful.
Yeah.
Um, the, I would just want to mention to everyone to use the chat button to ask questions right now if you want to, because the other questions that I have deal with what you're going to speak about next, which is the COVID-19 clinical trials, and that's what the rest of the questions are about. So, so if anyone has a question right now, before we move on to the COVID-19 treatments, please just press the chat button and type in a question. Or if you want, you can also, there's a way to raise your hand, and it just gives you it makes you have a little green circle around your square around you, and then that way I can unmute you so you can ask your question. So is any other questions at this moment, or should we move on?
Come on, I'm tired of hearing my own voice. Somebody unmute yourself and ask a question.
Right, you can unmute yourselves.
No?
Michelle, can you hear me?
Yes.
I have a question. I'm scheduled for a bone marrow biopsy Friday,
Mm-hmm.
and I'm wondering if the doctor recommends getting tested for COVID prior to that procedure.
Before the bone marrow biopsy?
Yes.
I think different institutions will have different policies about that. At our institution, you would not need to be tested for COVID prior to having that particular procedure at our current guidelines. To start chemotherapy, you would. So if you were starting a brand new regimen for the first time, or we were switching your therapy, particularly if it's ones like proteasome inhibitors or CD38 antibodies, which may impair your capacity to fight viral infections, we are doing COVID testing before starting treatment. I think you'd need to check which. I don't know which institution you're having the bone marrow biopsy at.
A U of M.
At U of M. So, the best thing to do is call them and find out what their institutional policy is about that. Most centers now have, most large centers have in-house testing where you can get a result within anywhere, depending on what platform they're using, anywhere from 15 minutes to 2 hours, but it's definitely same day and fast enough to get results back before you actually do stuff. Mm-hmm. Yep. I think this is a tough question. Like the whole subject of how do you keep patients and healthcare providers safe during this whole process. Nobody right now has any good data about the prevalence of COVID infections in the general population, let alone in myeloma patients. We don't know we don't know how high the rate is, and we suspect that the rate may be even higher in patients with immunocompromised for whatever reason, including myeloma. I think there's going to be a major effort by probably groups of centers working together to start doing prevalence studies. So that is regular, sort of mandated testing, like what you're asking about, like periodic testing, and then one thing that needs to be worked out is how do you do that? Is it just like the next time everybody comes in, you test them, or do you start a routine testing policy, where everybody gets tested every time they come in, or everybody gets tested quarterly, plus if they develop symptoms? I mean, that's hard because the fact is that there's a sizable percentage of totally asymptomatic patients who get infected with, COVID. I have a smoldering myeloma patient right now who's wrestling with exactly that. He has no symptoms, but knows that he is infected because his wife had a symptomatic infection. So he got tested, and lo and behold, his test is positive, but it's not, he has no symptoms. And predictably, it's taken a long time for that infection to clear, because patients with multiple myeloma often don't make antibodies as vigorously as average people. And so even though he's had no symptoms, he's had positive nasal swabs for 8 weeks now. Wow. So it's, and if his wife hadn't been diagnosed, he never would have had a test. And he's a great illustration of the issue that we all face when we're trying to sort of, predict risk when you start treatment, predict risk when you're doing a procedure, predict risk just by bringing somebody into clinic, right? We want to do that kind of prevalence testing. The other thing that we're all very interested in doing is the antibody testing. Right now, there isn't a standardized, sort of gold standard validated antibody test, but there are a lot of different companies that have antibody tests out there that are being used or in some stage of the process of being evaluated by the FDA. And once we have a gold standard test, it's going to be very, very important for us to understand how myeloma patients and amyloidosis patients at different stages of their therapy, when they're on maintenance therapy, when they're post-transplant, when they haven't been treated yet, like how do they mount antibody responses, and how does that compare to the average people, and what does it mean for future immunity from infection? So we and others are collaborating to learn those things. The Multiple Myeloma Research Consortium is one of several organizations that are very, very interested in these kinds of questions.
I have another question that came up on the Q&A right here. This is from Judy. It says, is CART procedure proving to be successful for multiple myeloma?
Yes. So CART is CAR T cells, which is a form of immunotherapy. It's cellular therapy. And what CAR T cells are patients' cytotoxic lymphocytes, which are immune cells collected from the patient, sent off to a lab, and then modified in a way that makes them able to target the myeloma cells. And then they're expanded so that there's more of them, and then they're given back to the patient through the IV as a form of active immune therapy against their own myeloma. And I would say the short answer is yes, they have been successful in myeloma. I would also say that we are still very, very much on the steep side of the learning curve with these agents. All of the CAR T cell platforms that are at all close to being considered for FDA approval target something called BCMA, B-cell maturation antigen, which is a surface marker on plasma cells. There are other therapies that also target this. There's the antibody therapies. There's something called bispecific antibodies or BiTE molecules, which target BCMA. And all of them have real response rates. CAR T cells have extremely high response rates. every study that's been done in the like 70 to 95% response rates in heavily pretreated patients. So when you compare, when you compare the effectiveness of CAR T cells against, say, daratumumab or Velcade or Revlimid or Pomalyst in the same patient populations that it's being tested in, you don't get anywhere near those kinds of response rates. With single agent drugs, any of those drugs that I just named, when you use them in the kinds of patients that CAR T cells have been studied in so far, single agent response rates are like 25 to 35%. Okay, so CAR T cells definitely have major league activity. And the other really sort of notable thing is it's not just that the response rates are 2 to 3 times higher than the response rates with these other drugs in the same setting, but much, much higher rates of complete responses and even super deep responses called MRD negativity or minimal residual disease negative, which means using technology that looks for like one myeloma cell out of a million in the bone marrow, you can't even find one myeloma cell, right? And so really, that's fundamentally different than older therapies. Now, the other things that it's important to know about is that CAR Ts are not without toxicity, and sometimes the toxicities can be quite significant. There's something called cytokine release, which is like a systemic inflammatory reaction that sometimes can be quite serious, sometimes requires ICU level management. And then there's also neurologic toxicity, which can sometimes be a little bit delayed and can be quite significant, ranging from balance problems to seizures, and sometimes that can be lasting. Because there is real toxicity, and also because we don't know about the effectiveness of CAR T cells yet in earlier patients, like for instance, in the place where we would normally be using transplant now. I think the jury's out about what CAR T cells will eventually mean and how they'll fit in and how they will shape the treatment landscape. But the preliminary signal is extremely exciting. And all of us are, expecting that there will be CAR T cells approved for multiple myeloma, and then eventually they'll be studied earlier and earlier in the course of the disease. And it'll be easier to do that, especially as we start understanding the mechanisms of toxicity better and start learning how to hopefully prevent some of the worst toxicities like the neurologic toxicity. It'll be easier to study those cellular therapies early.
So those are the questions that I have right now from the group. Do you want to move on to talking about your clinical trials in COVID-19? And we'll also
Sure.
ask people to just please use your chat button if you want to ask a question. I have a few for the COVID-19, but you may even cover these when you're talking.
Sure.
So,
So right now there's no standard therapy for COVID-19. There is data that many of us have heard about. Remdesivir is an antiviral that seems to shorten the course of infection in some people. It has, I would say, modest activity, but clear activity. Other compounds that have been used up to this point probably are going to turn out to be less effective. Hydroxychloroquine is the biggie that I think a lot of us have heard about, either by itself or in combination with azithromycin. There's mixed data on these drugs, but right now the bulk of the data suggests it doesn't do an awful lot. Us in the medical community, while the news cycle was sort of raging about the evidence related to hydroxychloroquine and should people be going out to get it and blah, blah, blah. The fact of the matter is that on the ground, in the field, in hospitals where people are being treated for COVID, most hospitals were using tons of hydroxychloroquine based on the preliminary data. until the larger studies came out. I mean, Karmanos and Henry Ford and the St. John's in the Detroit area, all these hospital systems were using hydroxychloroquine in the early part of this outbreak. And, the data that has emerged from Michigan, I think, isn't a randomized study, but I think you can say with certainty that if hydroxychloroquine was a major game changer, that Michigan's numbers wouldn't look like they do, because most patients in Southeast Michigan, where the concentration of the infections were happening, frankly, were getting that drug, off studies. More recently, I think it was Henry Ford was doing a hydroxychloroquine study, and we'll wait to see what the results show. But most patients were getting hydroxychloroquine before any of the most recent data came out. So in terms of research that's going on at Karmanos right now, we have a few studies open, actually. One of them I'm the principal investigator on, and I just, for the purposes of disclosure, it's a drug that is made by one of the sponsors of today that you mentioned, Karyopharm. And I would just like to clarify that I don't have any personal stake in, the outcome of this study, other than, the stake I have in caring for my patients. So I'm not speaking on behalf of Karyopharm, and I don't have any conflict of interest related to, reimbursement or anything like that related to this study. But the drug that we're studying is called selinexor, which is an approved drug in multiple myeloma. Selinexor was approved, I think, just last year, and it's a drug that is approved for use in combination with dexamethasone for patients who've had at least an IMiD, a proteasome inhibitor, and a CD38 antibody. It's an oral medication, and a drug that has modest activity by itself or with dexamethasone in myeloma. The response rates are about 20 to 25% in relapsed patients. Its probably best use is going to end up being in combination with other myeloma drugs. There was recently a positive study called the Boston study using it in combination with Velcade, and adding selinexor to Velcade led to better outcomes compared to just Velcade. And I think that's predictable based on laboratory bench work that showed selinexor synergizes with drugs in the Velcade family. We've also done research with the related drug carfilzomib and selinexor. And other groups have done research using, in combination with other antibodies or other chemotherapy drugs. There's also a lot of evidence that the drug will have use in lymphoma, maybe solid tumors like pancreatic cancer, in combination with other drugs. So it's a cancer drug, and it's a cancer drug with broad potential applicability. The way that it works, the way that it synergizes with other chemotherapy drugs, is it blocks a transport complex between the nucleus of the cells, the cancer cells, and the cytoplasm of the cancer cells. Think about, for everyone, I mean, if we go back to like our biology classes from, high school and college, the nucleus of the cell is sort of like the brain of the cell, right? It's where the chromosomes live. It's where, it's the control center for the cell. And it's where a lot of chemotherapy drugs exert their toxicity against the cell, but cells can resist the effects of chemotherapy by shuttling certain proteins out of the nucleus into the cytoplasm of the cell. And when you can't shuttle those proteins out, it makes the cells more susceptible to the effects of other chemotherapy drugs. Viruses propagate within cells by getting into the nucleus, inserting their genes sort of into but hijacking the replication mechanisms of the host cell, and then shuttling viral materials back out of the nucleus to the surface of the cell where they can be released to infect other cells. And so that process of shuttling things back and forth from the nucleus to the cytoplasm, even though it's a different set of proteins and molecules, it uses the same channel that cancer cells use to resist chemotherapy. And so by blocking that channel, you block viral replication. And so the idea is you can sort of shut down the virus's ability to keep replicating within the host by using this medication. And there's all sorts of preclinical data to show that this happens. And there's also preclinical data to show that this isn't really just unique to COVID-19. They actually have preclinical data about influenza, RSV, other important infections that we all see in the clinic. And so the exciting thing about this trial is it's a totally new application of this cancer drug to something that isn't cancer, but it's also a proof of principle study. If it works against COVID-19, I think it will fuel a ton of research about other infections that are just as prevalent, like influenza, where there's tens of millions of infections per year in the United States. It potentially introduces another therapy, for that type of infection. So, we're excited about this trial. The trial that's ongoing right now is open at about 40 centers internationally. It is a randomized study. For every 3 patients that are enrolled, it's blinded, so nobody knows who's getting what. But for every 3 patients enrolled, 2 actually get the study drug, selinexor, and 1 gets placebo. But any of the other therapies that people have heard about, remdesivir, tocilizumab, hydroxychloroquine, any other available treatments that are being used right now to support patients with COVID-19 are still usable. So you're not forbidden from trying other things that have been shown to be helpful. It's just whether adding this drug to those other measures further improves outcome. So placebo-controlled, but not placebo only. You still have access to standard therapies for this trial, and that's the only ethical way to do it. I mean, you can't deny people access to antiviral therapy. If there's emerging data that it's available, and so that's the trial.
So, Dr. Zonder, these are some of the questions we have regarding this. How were you chosen to spearhead this trial? Is it something that you did, or is
so spearheading it? So I'm spearheading it at Karmanos, and again, it's a multi-center study, and it is an industry-sponsored study. So I mean, it's a karyopharm study. I'm spearheading it at Karmanos because I have a lot of experience with this drug already through our lymphoma research, and also, our myeloma research, and also through a lymphoma protocol that I helped develop here. And also, I mean, frankly, the timing was right. Not only do I have experience with the drug, but I also happened to be the inpatient rounder this last few weeks. And so I was going to be the person rounding on inpatients, and it's for patients who are inpatient. And so it was a pretty easy decision to make internally at Karmanos that I was going to be the person leading this trial at Karmanos.
How long has it been going on now, this trial?
Going on for just a few weeks. Really a pretty amazing story in the sense that because it's so urgent, the approval process for the study nationally was just super accelerated compared to a typical study. Like a typical selinexor study for multiple myeloma, our center is actually one of the faster centers in terms of getting studies open, and it would take 3 to 4 months to get the study open. From the day that we received the first information about the study to the day it was open was like 14 days for this particular trial. It was unbelievably quick. And most centers are able to do that too, because it's just the recognition of the urgency of this. It's moving really, it's moving really, really fast.
So how long is the length of this time-wise? Like when will people have any kind of, when will there be data enough to know if this is working? Or
So we already have, so the way the study is designed, therapy is short. It's not like when we use it to treat myeloma. When we use it to treat myeloma, it's repeating cycles over and over time, just like any standard chemotherapy drug. With this trial, it's 2 to 4 weeks of treatment. And, 3 times a week for 2 to 4 weeks, depending on how a patient's doing on it and how the patient's infection is going. It'll be, I think the total number of patients in the trial is like 250 patients. There's already about 50 patients enrolled on the trial. There was a brief pause after 40 patients were enrolled to do a quick safety check to make sure that we weren't seeing any bad safety signal related to the therapy. Again, the hydroxychloroquine story is a great example, right? Like once we started getting data, we saw that there were actually cardiac complications in some patients. So with this, we wanted to do a very early look, and it turned out there was no unexpected safety signal. And the study, after a very, very brief pause, opened back up to continue enrolling. It's moving quickly. I expect that this study will probably be fully enrolled within 2 months at the rate it's going.
That's really interesting. That's great. That's
yeah.
And so can you see anything so far? Do you think that or is that something that is too early to tell?
Well, so it's a little bit too early to know. All I can say is that it passed the safety pause and has moved on beyond that initial safety pause. Mm-hmm. So that's where we're at. The fact of the matter is we don't, because it's a blinded study, we don't have any efficacy data yet. So we'll see. I think, unlike a cancer study, where it may take, 6 months or 12 months or 2 years to see how a new therapy stacks up against an old therapy. This isn't going to, because the disease course, sort of runs over a period of weeks and then is done in patients, we're getting data in efficacy data in almost real time within just a few months, if that, of the end of accrual. We should have we'll already know the outcomes of every patient. So we should have, I expect we'll have an answer to this study, I would guess by, year's end.
Sure. That's great.
Mm-hmm.
I have a question that came up through the chat. You mentioned using selinexor with other chemotherapies. Is DARA one that is possibly advantageous compared to others?
So it's been studied. Duke University spearheaded a study of selinexor daratumumab, and it looked good. to my knowledge, that's the only study so far where that's been done. So, I mean, it's not a randomized study. I mean, but I guess I would say is it's being looked at, and the preliminary study showed very promising efficacy, higher than the efficacy you'd expect from just daratumumab. So we'll see.
Okay, that's great.
Mm-hmm.
Do we have any other questions? You can unmute yourself and ask a question if you'd like. This is all pretty exciting stuff, I think, to get this far so quickly with clinical trials that are going on across the country.
Mm-hmm.
Oh, okay. These I think are probably things that we've already covered, but another question was, who or how was the myeloma treatment discovered for as an option for COVID-19? And you kind of covered that a little bit, but it was one of the questions asked.
Yeah, I mean, this is so the company that makes the drug has been looking at all sorts of different potential applications for this drug beyond cancer. I mean, one of the other ones is actually dampening inflammatory reactions, right, which would have relevance for autoimmune diseases and arthritis, but also may be part of the rationale for studying it in COVID, right? Because I mean, the subset of patients, that die of COVID typically have a major exaggerated pulmonary inflammatory reaction. And it's usually like this, people have heard ARDS, adult respiratory distress syndrome, like they get this terrible inflammation in their lungs and fluid in their lungs, sort of leading to irreversible lung injury and inability to ventilate them adequately. That's actually part of what's being looked at in this study, is not just, is there a difference in survival or a difference in the length of hospitalizations, but, what about like pulmonary outcomes specifically? Is there a difference in the rate of intubation? Is there a difference in the duration of intubation? This is capitalizing on lots of sort of biology, lots of knowledge related to this drug, and a lot of research that the company's poured into different pathways and cellular mechanisms that are affected by this transport channel in the cells.
That's interesting.
Because these are normal channels that all cells have.
Mm-hmm.
Some of our targeted therapies in cancer, right, they target a mutation or some abnormal protein that the cancer cells have that normal cells don't. This does not target that. This targets a normal transport channel that just happens to be important for cancer resistance. And so that's why it has potential applicability outside of cancer, because it does have mechanisms besides cancer, cancer resistance.
And have you seen any side effects, any bad side effects? I know you did the pause, but are there other things that are happening besides?
So the drug is known to have side effects. It can cause low sodium levels. It can cause very severe fatigue. It can also cause real GI side effects, and that can range from diarrhea to anorexia to nausea and vomiting. In fact, when we use it in combination with other chemotherapy drugs in myeloma, we are usually using it at a lower dose than what's approved by the FDA, because it's a dose-dependent toxicity. In this particular study, we're using it at much lower doses than we use than it's approved for in myeloma. So we expect that, I think we expect to see some GI toxicity. I think we expect there will be some patients who develop low sodium levels. There may be a difference in certain other side effects like fatigue. But I expect that they will be less than the rates and severity at which we saw them in oncology trials. And, and the other thing is, those kinds of side effects mean something different when you have them for 2 to 4 weeks than if you have them for 2 to 4 months or for 2 years. Um, you know, um, Moderate diarrhea for a few weeks doesn't have as big an impact on somebody's life overall as it would to have that same side effect every day for 6 months.
Do you have any words of advice, I guess I would say, for patients with multiple myeloma as it relates to COVID-19 and best practices? I mean, people are worried about going to see their doctor. People are worried about leaving the house. People with multiple myeloma typically have compromised immune systems,
right?
Perhaps. So can you give us any sort of advice?
So I think that, first and foremost, maintain contact with your doctor, whether it's by phone or telehealth visits. Don't allow yourself to fall through the cracks during COVID. And also don't consciously jump into one of those cracks during COVID where you go into hibernation and avoid seeing your doctor, and don't get the follow-up you actually need to monitor your myeloma or amyloidosis. I would say talk with your physicians about whether your therapy needs to be modified to either oral medications or a change in the schedule to minimize the number of visits for for IV or subcutaneous therapies. Is there a way to modify the schedule so you're going in, once every month rather than once every week? I think that's important. I also think that it will be eventually it will be important for all of us to sort of know our immune status against COVID. And once testing for antibodies becomes more reliable, I would encourage everybody to find out, once we know we have a good antibody test, and once we know what having antibodies means, because we don't know that yet either. We don't know if that really makes you immune or not to have the antibodies, but we think it does. Or we think it makes you immune to this wave of COVID-19 at least, is probably to make sure you know what your immune status is so that you can conduct yourself accordingly in the world, right? I think that's a challenge for all of us. How do we, what are each of us going to allow ourselves to do? How are we going to interact with people? How are we going to frequent businesses? Things like that. And the answer to that question will be affected by things like, am I on active therapy right now? Am I not? Do I have antibodies right now? Do I not? Do I have other illnesses like emphysema or asthma, or clotting disorder, which might make me more prone to problems related to COVID? I think all of those things need to be taken into consideration. We're going to be emerging from this hibernation we're all in right now back into a world which is not as dangerous as the last 3 months have been, but is not going to be as safe as 3 years ago seemed. And we're going to have to figure out how to navigate for ourselves as we do that.
Okay, that's good advice. It's I think it's good advice for all of us.
Yeah, I think all of us to varying degrees have those considerations to make so that we can, to guide our own sort of behavior, right? Because, at some point, we're going to all have to figure it out for ourselves.
Do you have any kind of idea as far as time frame, and this is probably a question you might not know the answer to, of when we will be able to have a test for antibodies?
Well, right now there are about a dozen different companies that have tests out there. Some of them measure IgG antibodies, which looks for past exposure that was quite some time ago. Some of them measure IgG and IgM antibodies. IgM antibodies look for more recent infection. So some tests measure both, some tests only measure IgG, and none of them are validated right now. So I mean, you can already get that testing. I have at least a dozen patients who have gone and gotten antibody testing. I was texting with 2 people this morning about their COVID-19 antibody test results. So it's it's available, but we don't know what the best test is. We don't know if when you get it done at Ford, is it as good as if you get it done at Beaumont? Is it as good as if you get it done at Karmanos? Is it as good as if you get it done at Michigan? We don't know because they're all using different assays at the moment. So my guess is within 3 or 4 months, we'll probably have some information that lets us conclude which are the better tests to use. Might take a little longer than that, but my guess is it'll be a few months.
That's encouraging, I think. We've passed our hour, and I do want to open it up to anybody else. If you have a question for Dr. Zonder, I don't want to use up too much of Dr. Zonder's time, but this is your time to be able to ask if you've got a question. You can unmute yourself and just ask, or if you don't, that's fine too.
Yep, Michelle, jury off, I have one.
Okay.
Referring back to, Doctor, what you said earlier about inflammation, Dr. Dury has written up in a couple of his recent blogs that because multiple myeloma or the drugs taken with multiple myeloma don't necessarily cause the inflammation problems that some of these other diseases do, that there might be some slightly less susceptibility of multiple myeloma patients to get COVID-19. What's your thought on that?
I don't think we know that yet. I think some people are wondering whether drugs in the IMiD family specifically, Pomalyst, thalidomide, and Revlimid, whether those drugs may actually have a beneficial effect. I think all of us are very worried that other drugs, like steroids, Velcade, Velcade, other drugs in the Velcade family, daratumumab, elotuzumab, worried that drugs which can lower lymphocyte counts may actually make you more prone to viral infections and more severe viral infections if you get it. So I think the jury is out. I don't think it is a given, and we are highly, highly interested in this question, and this is one of the reasons to do registries, right, to collect data on patients and analyze it. I think it's highly likely that not all myeloma therapies are equal in terms of the risks and benefits as they relate to COVID. And so I'm sure there will be some drugs that would be safer to be on than others, and we just need to figure out which ones those are. There's going to be a lot of work focused on that for sure.
Okay, anybody else have a question?
Michelle.
Yes.
Nancy Haida, I was late in getting in, and you probably asked my questions already.
I did, Nancy. But you would like let's see if I can find your questions again.
Well, I know what they are.
Go ahead.
Was it the cataract question?
Yeah, they were the cataract. The cataract and the also loss of vision from Revlimid.
Yeah, it's probably not the Revlimid. It's probably the steroids that you get with the Revlimid. Dexamethasone, definitely.
No, I'm only on maintenance, 10 milligrams of Revlimid.
Yeah, so Revlimid probably not. It's not ocular toxicity is not a major issue with the drug. It may be though that past past exposure to steroids, for instance, may have
Okay.
accelerated the formation of cataracts, and you may have cataracts that are more severe now than they were a year ago, for sure.
Okay, I think that's what's going on. The other question regarding the shingles vaccine for a transplant.
The answer is yes, for sure.
It is.
We
Oh,
do
okay.
recommend. I mean, at Karmanos, we're very pro Shingrix vaccine for our post-transplant patients, and frankly, for our myeloma patients in general. It's not a live vaccine. Being post-transplant or being on other therapies doesn't put you at any extra risk related to that vaccine, and it is a very effective vaccination.
Okay, when I had my immunizations, that was not on the list.
It's not standard at most transplant centers. It hasn't been
Well-
part of the traditional vaccination schedule post-transplant, but there's no reason you couldn't get it, and it's available at any pharmacy.
Okay, great. Thank you.
Mm-hmm.
Well, I think that we should probably end this now because we are over the time. And thank you again, Dr. Zonder. We really appreciate your time. This is all very, very interesting. I know it was interesting to me, and I'm sure it was to everybody else in the room.
Thanks.
We will try to do some more of these. Hopefully we can meet in person sometime, but
Yeah, with real lunch.
Yeah, right, a real lunch sometime soon. So anyway, thanks again to our sponsors as well. And everyone stay safe. And hopefully we can connect again pretty soon.
Okay.
Yeah, if there are any questions that come up after this, and if you, you could maybe compile any questions that come up because you're the one who's in touch with everybody. And if you want to send them my way, please feel free to. Okay.
That's great. I will do that. If any of you
Cool.
have questions, you can just reply to my login email that you received, and I will forward them to Dr. Zonder, and we'll make sure that we get your questions answered.
Cool. Okay. Thank you so much, everybody. It was really
Thank
nice.
you. Thank you,
Thank you
everyone.
very much.
Okay. Bye.
Bye-bye.
Bye.
Hmm.